space for conversation around women's health through the lens of naturopathic and Eastern medicine. I am Sandy Ross, and this is Her Earth Medicine Podcast. This podcast is multi-leveled. Episodes for patient education to graduate practitioner level. Thank you for tuning in, and I hope you gain value from this episode. Today's podcast episode is about the first trimester of pregnancy, and we'll be discussing this with Midwife Emily Ross. Since graduating in 2016 from Griffith University, Emily has worked in the antenatal clinics, the birth suite, maternal inpatient unit, special care nursery, neonatal inpatient unit, complex high-risk pregnancies working in the maternal fetal medicine department, the high-risk birth centre midwife group practice providing caseload midwives to those with high-risk pregnancies. And currently, Emily is part of a first ever hospital in-home care for women who ordinarily would be inpatients in their pregnancy. So she's got a wealth of knowledge, and I thought she'd be perfect to kind of debunk some things that we want to know around pregnancy. Emily also helped deliver my two beautiful children, so I think she's an amazing midwife. So let's welcome her to the podcast. Welcome to the podcast, Emily.
Hello, everyone.
Thanks for joining us today, Em.
Thank you for having me.
Emily is my baby cousin, and I had to convince her to come on here. She's a little bit shy, but she is a wealth of knowledge in everything related to pregnancy and postnatal care. So I'm super excited to dive into a few layers. In this podcast, we're going to try and focus on the first trimester, I believe. We'll see where it goes. And then we'll break it into a few segments to discuss the second, third labour, and then the postnatal. So check out those episodes following this one. So Em, do you want to tell us a little bit about yourself and how you became a midwife?
Sure. So it's not a very exciting story, to be honest. I was finishing high school, and I actually was enrolled to do a Bachelor of Psychology and was really interested in the whole world of counselling and therapy and all that kind of stuff. But I was being a bit indecisive about doing that and thought it was quite an intense career path to have to go down. And so I deferred my acceptance, and about a month later I was talking to a friend who'd recently had a baby, and she was telling me about her birth experience and her midwife who looked after her. And I, honest to goodness, didn't even know you could do that as a job. I thought that doctors delivered babies and that there was no such thing as really a midwife. And following that conversation, my mind kind of just exploded, and next thing you know, I'd enrolled to do a Bachelor of Midwifery and went in pretty blindly. I didn't really know what I was getting myself into. The first time I saw a birth, I didn't even know what a placenta was, so that really freaked me out. Yeah, when I saw that coming out, I was like a bit scared, but anyway, and so that was about nearly 10 years ago, and here I am now.
So Emily's actually had the pleasure of helping me deliver my two children. She almost missed the second birth, but she made it, and she's an amazing midwife. So first question I want to dive in with is, I think a lot of people, once they actually conceive and they look at the pregnancy tests and they see the double lines, they sort of don't know where to go. What do they do? What's the first move they should make? So can you answer that on, what's the sort of first protocol?
Yeah, sure. So just to give a little background, midwives, especially in Australia, I know it's different in different countries, but we actually don't tend to start caring for women until you're almost in your at least second trimester, with exceptions, of course, but we do know a lot about first trimester and all that kind of stuff, but usually your GP will kind of lead your care in that respect. But the first thing you should do if you have a positive pregnancy test is book in to see your GP. It's really important to actually confirm that you definitely are pregnant, because pregnancy tests can be false positive. The next thing that we get your GP to do is order your baseline antenatal bloods. And most importantly, if you're wanting to birth in a midwife group practice or a birth centre, the earlier you get your referral to them, the better your chances of actually getting a place with them. And I think we'll talk a bit more about models of care a little bit later. But basically, yeah, first thing you should do is go and see your GP.
Okay, and so if someone's pregnant and they haven't planned a pregnancy, what about prenatal supplementation? What's the midwife's view there?
That's an interesting topic, because midwives versus what a GP will recommend versus what a naturopath like yourself would recommend might be a little bit different. There is a really, really well-known supplement on the market that a lot of GPs will recommend women take. I'm not
a fan of.
Yeah, no, neither are midwives. So I won't say what it is, but it's a little obvious. It's very well known. What we find is women get really nauseous from taking it, first of all. So their nausea just increases, because I think there's a lot of vitamins and minerals that have been put into it, which
just lingering in the gut, it's not absorbing very
exactly
well.
Yeah. And what I also find is women think that they're getting enough iron, because it does contain iron in the supplement, but not enough, or I don't think the body absorbs it at all.
Not in that form, yeah.
No. And so women become really anemic from taking it. And even the representatives from that company who come and do education with us will tell us that the folic acid that's in the supplement is only really necessary for the first 4 weeks when the baby's neural tube is being formed, and that's where you need the folic acid. So it's one of those things where I wouldn't waste your money, to be honest.
Obviously there's lots of different brands and stuff like that, and this is probably a topic for another podcast, but I think one of the best things to look out for is you do want folic acid about 400 micrograms max, because if someone has that MTHFR gene mutation, and this might be something someone's listening to for the first time, then they don't metabolize it into folate, and so that's why some good supplements will have a little bit of the activated folic acid in there, which is what we call the folinic acid.
Yeah.
So at least they're metabolizing it. But that's a topic for another conversation. I think some of the prenatal nutrients that people miss out on is like your DHA from your fish oil and choline, which you can get through like eggs, cauliflower, broccoli, and some meats. But they're actually like so important for fetal brain development, and iodine is another one. Like I said, this is a topic for another conversation. I want to talk to you more about the first trimester, but I think it is something, if you're pregnant, to look out for, and you can always go and speak to a naturopath in a health food shop or a nutritionist to find out more. But anyway, moving on from that, the models of care, do you want to talk to us about them?
Yeah, sure. So this is a topic that can get confusing, because depending on what hospital you're actually birthing under, the models of care will be different. I work on the Gold Coast at the Gold Coast University Hospital. So we also, during COVID, unfortunately, it has changed a lot of our models of care for women who would be just under a midwife model of care, because we're trying to reduce the amount of contact women are having with the hospital. We're doing a lot more GP shared care, so you see a midwife and a GP and you kind of alternate between the two. But basically, in a nutshell, the first one, which I mentioned earlier, is called a midwife group practice or birth centre. Super confusing. They're both the same thing. They just have two separate names. Basically, that is a government-run and hospital-run program where you book in with a primary midwife who works on a team. Usually it's based on what suburb you live in, so they get allocated basically a suburb so that they're not driving across the entire country day to day. So she works on a team. She'll be your primary midwife. Whenever she gets your referral and you guys arrange an initial appointment with you, she'll take over your care. That midwife will see you through your pregnancy. She'll be on call for you when you go into labour, and she'll come out to your house and provide postnatal care in the home for up to 4 to 6 weeks postpartum, depending on how much care you need, basically. I say that she works on a team because the other thing to keep in mind is that whenever we work in that model of care, midwives do have days off where they're not on call. So if you were to go into labour on your midwife's day off, then her teammate will take her phone and vice versa. So you primarily will get the same person, but sometimes it will change. depending on when you go into labour, which obviously isn't very predictable. The idea of the midwife group practice is that the emphasis is on achieving a low risk kind of normal birth outcome. So it doesn't mean that we don't do things like cesarean, induction of labour or epidurals or all those kind of things. We still do that, but we try and support women to do essentially what your body is designed to do. So go into labour spontaneously, birth naturally, birth with less pain relief. The research shows that when a woman births with a known and trusted care provider, she actually asks for less pain relief than women who birth with someone they don't really know. And the idea of it also is to have an early discharge from hospital. So if everything's normal with you and baby medically and everything else, you can go home 4 to 6 hours after you give birth and then get all the postnatal care at home.
Yeah, it's a pretty good setup. Are you happy with the model of care that's arranged? Do you think there's things that you would tweak?
I just finished an 8-month contract working in the birth centre, which was awesome.
We have a storm, sorry guys.
It was a really, really good job opportunity, but unfortunately for me, my stress levels were too high working on call. I found that overnight, whenever you're on call, I just felt like I didn't sleep very well because I was constantly stressing about whether I was going to get called or not. And after 8 months of that full time, I had to have a break from it, which there's nothing wrong with that. I think in a job like that, it's really important to look after yourself first and foremost and have breaks if you need to feel like you need to have a break. Sorry.
Yeah. You want midwives feeling at their best.
Yeah,
babies.
Exactly. Yeah, and I felt like I was starting to get to a point where I wasn't giving the best care I'd like to give because I was feeling really burnt out, to be completely honest. There's some midwives who are amazing and they do that kind of job for 35 years of their career and they're never fazed by it and they give amazing care the whole way through. That unfortunately just wasn't me, but currently the Gold Coast has 35 midwives who work on the midwife group practice and their caseload would be around 4 women per month. So they're providing quite a big number of care to the women on the Gold Coast, and the hospital is just trying to grow and increase the midwife group practice because they know that the outcomes are actually better for women, and all of our statistics actually reflect that as well. The other model of care, if you feel like if you've tried to get into the birthing centre and your referral has been declined, which unfortunately is really common because it's very, very popular and they just don't have enough space for all the women that get referred to them. If you can afford it financially, you can hire a private midwife. I'm not actually 100% certain on how they are running their clinics and stuff like that lately because a few of them have actually closed their businesses. Not all of them, but a couple of them have recently. But just jump onto Google and you can find their information on there. Again, it's quite similar. The earlier you refer yourself to them, the better, because they also have number capacity as well, and they can't provide care to every woman that they get referrals from. Alternatively, you can birth at the Gold Coast Hospital without a known midwife, but you can have continuity of care with a midwife during your pregnancy and postpartum. There's actually quite a lot of women who have that model of care and actually have really good feedback provided from that. So they book in with the same midwife who works in a community clinic in their suburb. They go into labour and just birth at the Gold Coast birth suite, and if they need to, they stay in hospital for 2 nights or 3 nights, and then they go home, and then the midwife that saw them during their pregnancy can provide their postpartum care as well. Those midwives also work on a team, I should say, sorry. So you're not necessarily guaranteed to see the same midwife every single time. It may alternate, but it's more of a personalised model of care. And most importantly, we've been running that kind of service for about, I think, 2 years now, and a lot of women have really, really positive feedback about it and are really satisfied with the care that they get. So the hospital is also expanding that model of care. And then the other model of care you can have at the hospital is you come in and have your pregnancy appointments with a midwife at the hospital. sometimes that will change each appointment, and you share your care with your GP. So you see the GP for your midwife for a booking an appointment, and then you see your GP till about 31 weeks, and then you alternate between the midwife and the GP. Yeah.
Okay. Yeah. And that's all the models of care?
Yep. Yes, that's all Yeah. Alternatively, you can go privately and book under a private obstetrician and birth in a private hospital, which I don't know too much about because I've never worked in a private hospital, but from what I know, women do tend to enjoy that model of care. The only thing I would say about that is when you're birthing with a midwife versus an obstetrician, and I have a lot of respect for obstetricians. I think they have a really, really tough job, and their knowledge is really incredible, to be honest. But what we know, and this reflects again in research, is that if you are birthing privately with a private obstetrician, you are much more likely actually to have a elective cesarean or emergency cesarean during your labour or an induced labour. And that's not trying to be unprofessional or discredit anyone's work or what they do. That's just facts, to be honest.
Yeah.
So some women actually seek that model of care because they want that kind of birth outcome. So, great. But if you're more looking at, I want to have a low risk birth and I'm looking at, trying to do things as naturally as possible, then birthing with a midwife is probably more what you'd be wanting to look into doing. Yeah.
Cool.
Yeah.
I think that gives people a good idea of kind of what they can get informed on and make their own decisions.
Yeah.
Okay, what I wanted to ask you about next was scans. Can you talk us through the kind of the scans that women are going to have to go and get throughout their pregnancy, if they're all necessary?
Yeah. So there's 3 main scans that we get women to do. The first one is around 8 weeks pregnant. We get you to do what we call a dating scan. The name might be a bit confusing. So it's called a dating scan. It doesn't necessarily mean that that's what we base your due date off. That's just the name of the scan. Essentially, there's 2 reasons why we want you to do that scan. The first one is to confirm a viable pregnancy. The second one is to make sure there's not more than 1 baby in there. Yeah. So that's all that we really look at, and confirm that there is a heartbeat and that there's 1 baby and it's growing in the right spot, so you're not developing what we call an ectopic pregnancy where the baby's implanted outside your uterus, basically. Okay. And then from there, the next scan that we get you to get is we call it a nuchal scan or 12-week ultrasound. That one is done in conjunction with some blood tests that you can get done. Essentially, we're looking at the same sort of things. So we do look at a bit of the structure of the baby. By that point, a lot of baby's organs and everything like that will have started to develop. The other thing that we're actually screening for is the baby's genetics. So we're looking at the risk for genetic abnormalities in the baby. We call it a nuchal scan because we actually measure the nuchal fold, which is a fold of skin behind the baby's neck. We measure that, and we know that babies, say, with a genetic abnormality such as Down syndrome, actually have an increased nuchal fold thickness. So if we see that on the scan and some other abnormal features, we would then say that you are at an increased risk for genetic abnormalities such as Down syndrome. The other thing that we do is we look at mum's age, and then we look at mum's growth, pregnancy hormones and other chemical things in the body. And all of it is what we call a combined first trimester screen, and it essentially is calculating your risk for genetic abnormalities. So really important to know that that's not a diagnostic test. If you were to get a high-risk screening test, we would then do further testing to confirm whether there is definitely a genetic abnormality. So I actually worked for about 6 months in a department where we would get referred women like that. And what I saw through my own anecdotal experience is that sometimes, and actually quite a lot of times, you can get a high-risk screen that's actually a false negative. So it's pretty important to continue with your testing if you are wanting to rule that out. Unfortunately, sometimes they are positive and they do pick up on things that are actually in fact there. And that's, I guess, probably another conversation with what you would do going from there. But we do have some pretty conclusive tests that we can do on babies if there is a genetic abnormality with them. So we can actually sample the baby's DNA in pregnancy, and that will 100% specifically tell us whether the baby does have an abnormality or not. Yeah. The next scan that we get you to do is what we call a morphology scan. So that one is done between 18 to 22 weeks. That one, we're actually looking specifically at babies' organ structures. So the reason we do it then is because they're big enough to be able to see, but the baby's not too big that we actually can't see the structures, if that makes sense. So some people do a late morphology scan because they miss it, and it can be problematic because it's really difficult for the sonographer to be able to see the different things that they're looking at. But it's really looking head to toe at the baby to make sure that its organs and structures are all normal. The next thing that we also look at is your placenta and where it's located. So what we're trying to rule out is that your placenta is not growing too low to your cervix, which please don't panic if it is. I'd say 99% of the time your placenta will move out of the way as your uterus grows. It migrates up and moves out. So most of the time we just do a repeat scan in your third trimester to make sure that that has happened.
Thank you for mentioning that. I know that's a common one.
It's very common. And what I also tell people, especially at that morphology scan, is that it's really, really common to pick up little minor things that might be a little bit abnormal. I see it a lot with babies with little abnormality. I wouldn't even say the word abnormality, little markers, like say on their heart or in their kidneys or on their hands or feet or toes. Ultrasound is not, again, 100% diagnostic. So some things we can see on there that might look a little bit abnormal or strange, or might need to just follow up an investigation postpartum on the baby, but are actually fine, So all of these tests are really good, and they do pick up on things like that are quite severe and serious, but sometimes, you can pick up on things that actually aren't that big of a deal. So if you get a result that is not 100% perfect, please don't panic, is basically my advice.
Yeah, okay.
Yeah.
And that's all the scans?
Yeah.
Yep, okay. Let's talk about due dates a little bit, because this is, I think, as an acupuncturist that does inductions, this is one that I think can get tweaked a little bit with, they can have their due date change from the first one.
Yeah.
I know when I was pregnant with Nala, we calculated my due date, and then I think I didn't get a scan until I was really late in my pregnancy, and they changed the due date. They moved it forward, and so when I was late with her, we were going off my due date rather than the last due date that we were given, and it ended up aligning. So can you talk a little bit about due dates?
So it's a topic that used to really bother me back when I first started out as a midwife, because I felt like what I noticed anecdotally was that especially women having their first baby, often they would estimate their due date based on their period dates, and every time they'd get a scan, it would pull that due date forward by a few days to up to a week. And unfortunately what that means is you're at an increased risk of being offered an induction at the end of your pregnancy because you're quote unquote post dates, which you might not necessarily be overdue. So I certainly have cared for women in the past who've really stuck to their guns and gone, no, I've got my period this date. I know when I ovulated. I know when I conceived. I'm not due then. I'm due now. It is something that we call it an EDD, which is estimated due date. So keyword there being estimated. It's not 100% accurate unless you've had IVF with an embryo transfer, so you can clinically know exactly the day that the baby was transferred and what gestation it was when it was transferred over.
Exactly, yeah.
Otherwise, you actually don't know. So when we go off women's periods, and again, this is just what we do at the Gold Coast Hospital, the guideline will change depending on where you have your baby, but We only use women's period dates as long as they know, number one, that they have had a regular cycle, which a lot of women don't. So it's not really a reliable date. Second of all, if you haven't recently come off contraception, so if you've come off the pill and it's been less than 3 months since you've come off the pill, then we actually can't specifically use your period date as a reliable date because the pill can obviously interfere with your cycle. The other thing is we want you to be absolutely sure of that date. So a lot of women are like, oh, I think I got my period on the 17th, but I actually don't know for certain. So again, we need it to be a really accurate, reliable date to be able to use it. Otherwise, we do go off your scans. We use your 12-week scan to estimate your due date if you're not sure of your period date. So, which also confuses a lot of women because the dating scan, and I understand the name dating scan obviously can be quite confusing, is what a lot of women will then go off. But the measurements they take at the nuchal scan, according to research, are more accurate at estimating the baby's due date. And essentially those measurements are just taken off the baby's size. So how
much can come into that?
Exactly, yeah. So if you're someone who genetically grows a baby that's a little bit bigger than other people, then your due dates may be estimated a week forward because your baby grows a week ahead of what another baby would at that gestation. So basically, more or less what I tell women is not to get too attached to a date because only 4% of babies will actually come on their estimated due date anyway. So I call it a due month, and that's what I say to women.
I like that,
yeah, so you're due in September, and that's when you're due.
I'm going to use that.
Yeah, because
it stresses women out, doesn't it?
Yeah, it's a really big form of stress. Yeah.
And then the pressure's on not only coming from the woman, but the support network around them. It's like, is the baby here? Where's the baby? And
yeah.
people start saying, it's not safe now. And
yeah. So
a lot of pressure on.
I find that a lot of women's stress, especially if they do go overdue, actually is from their support people and everyone around them asking. So, I mean, it's up to you, and everyone is like, totally, it's fine what you want to do. But I advise people not to even tell people what their due date is for that reason, because as soon as you're creeping up to that date, all of a sudden the texts will be coming in and the phone calls and the harassment and the why are you still pregnant and da-da-da-da-da. 70% of first-time mums will actually go overdue. So it's very, very normal to go over your due date, and your baby is still developing. So research shows that even past and up to 38 weeks, your baby's brain is still developing, your baby's still growing, it's still relying on the blood flow from your body, obviously. So I think it's very normal to allow a baby to decide its own due date and not to try and force it to come out till it's ready. But I guess that's really a conversation more for the Labour and Birth podcast. We could go down
we'll touch
into that. Yeah, but it is a huge form of stress for women. So again, I guess take home message, it's a due month, and leave it at that.
Love that, that's good.
Yeah.
Okay, so back to kind of around the first trimester-ish. When should women expect to show?
Well,
Probably comes into the second trimester, really.
Yeah, I suppose it depends on your body composition, to be completely honest. So if I eat a bad meal, look like I'm 4 months pregnant anyway. So, and then some people, I tend to find taller women tend to carry a lot slimmer because there's more room for the baby to spread out, and shorter women tend to show a little bit earlier. But what I also find is a really big form of stress for women is being told that they look too big. I actually was just too small, yes. Yeah. I was just having a conversation with one of my colleagues who's a midwife who is, I think, 37 weeks pregnant, and she's like, everywhere I go, people comment on what I look like and the size and ask me if I'm carrying twins, and a lot of women that I see in the antenatal clinic will say the same thing. And it's always from a random stranger in the shops who tells them that they look too big, or are you sure you don't have two in there, or you must be due any second, oh my God, you're only 6 months pregnant, yada, yada, yada. So how you carry your baby is how you carry your baby. And unless you have had some growth scans and clinically proven that your baby is either far too large or far too small, please just ignore people's comments and try not to get too fixated on what you look like as well, because your body is going to change a lot during your pregnancy, and that's really, really normal. And yeah, everyone shows at a different pace. There's no right or wrong basically with that. It's just how your body carries. And also with each pregnancy, your body will carry your baby differently. And I can say that with like absolute fact, because women, especially if they're having their third baby, will say that they feel significantly more uncomfortable than they did the first time around. Basically, it's because physically your body has been stretched out, I guess, before, so your muscles and ligaments just aren't as supportive with each pregnancy. Exactly, yeah. It's stretched out isn't a nice way to put it, but I don't really know what other way to put it is. But that's where it's really important to work with a physio, with an acupuncturist, with all of those kind of things that can really support your body, because it is a huge strain that goes onto your body when you're pregnant. And again, what I find is the more times you're pregnant, the worse it can kind of feel.
Okay.
Yeah.
Good to know. Okay, and what are the guidelines you recommend for when you should be telling people that you're pregnant?
That's a really good question. I personally think it's very, very, very personal according to each person. I know that, you know, a lot of people will say that you usually tell people once you're 3 months pregnant because there's a high risk of miscarriage in the first trimester. But unfortunately, what I've found with that is that women who have recurrent miscarriage, so they keep having, for whatever reason, a miscarriage in the first 12 weeks of pregnancy, often find that they, because they don't tell people that they're pregnant, they're grieving a miscarriage in a lot of secrecy and silence, because no one even knew that they were pregnant in the first place. So I think it's really personal when you want to tell people, and there's really no right or wrong answer. However, I think, keeping in mind that if you're someone who likes to have a lot of support around you and likes, you know, your inner circle to be really involved in your life and all of that kind of stuff, and you want that extra support, I would, you know, tell them whenever you feel ready to, and don't worry about the 12-week rule, because I think that, again, miscarriage is a really, really common thing, and a lot of women have a lot of shame around miscarriage as well, and feel a lot of blame and guilt over that. So I think it's really, if that's something that you are struggling with, I think talking to people about it is actually better than pretending you're not pregnant, to be completely honest.
And it opens up the conversation to be like, oh yeah, you know, I've had miscarriages
too.
Like,
Exactly.
I so know where you're coming from, and then they'll support you more. And
and I think we're starting to do a little bit better about that. But you know, back in the day, pregnancy loss was something that was such a taboo topic that people weren't allowed to talk about, and it was something that's really, really, really common, and a lot more common than people realize. But again, it's something that women mostly have suffered in silence. So tell people when you want to, is my advice.
Okay.
Yeah.
Great. Okay. So when is it normal to start feeling the butterflies and the movements?
Well, that is also really individual. So there's a lot of factors that will come into play when you will start to feel your baby move. So if it's your first baby, what we expect is that you probably won't feel the baby move till closer to 20 weeks, and sometimes even beyond that. It also depends on the location of your placenta. So if your placenta is at the front and low down and your baby is behind that, whenever your baby moves, it will actually cushion the movements that you feel from the baby. So it'll make it take longer for you to feel the baby's movements. If you've been pregnant before, a lot of women will start to feel those kind of movements and feelings around 17 weeks is what I've noticed. But For women who haven't been pregnant before, so first-time mums, I would say usually it's around 22 weeks to up to 25 weeks before you actually start to feel baby's movements. And most women will describe is that they'll feel that butterfly feeling. So it almost feels like their stomach's lurching or something's fluttering around in there. And you might feel it randomly one day and then not feel it, for another week. And then eventually, slowly, you'll start to feel those up and down wriggly kind of movements. To be honest, I've never been pregnant before, so I don't know what a baby's baby's movement feels like. So I'm kind of just taking women's word for it. But more
I think that's around the 17 weeks.
Yeah.
It feels like a little butterfly.
Yeah. Just don't panic if it takes a little bit longer for you to feel your baby move than other people. Yeah. There's a lot that can play into that.
Okay, so one thing I just want to touch on is your perspective perhaps on prevention of gestational diabetes or glucose tolerance testing. It's a pretty big topic. I'm actually recording on Thursday a podcast with a nutritionist, Brittany Darling, so you can check out that episode for more insight. But I just thought midwife perspective, glucose tolerance testing, a lot of people don't do it. Where are you at with it?
Well, interestingly, because of COVID, for a few months there we weren't doing the glucose tolerance test for women because we didn't want women sitting in a pathology clinic for 2 hours. So for those of you who don't know, the glucose tolerance test is the test that rules out a test for gestational diabetes. Once upon a time, we only ever used to test women who had a risk factor for gestational diabetes. So for example, if you had a strong family history of diabetes or if you had an immediate relative who had gestational diabetes, you would be put in a high risk for developing it yourself. If you have pre-existing insulin-resistant diseases like PCOS or something like that, you'd be recommended to do not just a glucose tolerance test, but an early one to make sure you're not developing it before. We usually routinely test women at between 26 to 28 weeks. Women who have a higher BMI, so if your BMI is over 30, we recommend you do an early glucose tolerance test and then a repeat one at 26 to 28 weeks. However, due to COVID, we all of a sudden stopped doing the glucose tolerance test because it does take 2 hours. So first of all, we get 3 samples. We test your fasting blood glucose levels. So you come in the morning, you have your dinner, you don't eat for the rest of the morning. We see what your fasting levels are. Then we give you a drink. It's 75 grams of glucose. It's not a very popular test because a lot of people say that the drink tastes awful and it makes them feel really nauseous. So we give you that, get you to drink it, and then you are asked to kind of sit still because if you move around, you actually can burn up the glucose in your body. And we test your blood glucose level at 1 hour and 2 hours after having the drink to see how your body responds to that. And if your levels, we have like a guideline of what your levels should be, and if they fall out of that with each one of the 3 tests, then you're diagnosed with gestational diabetes.
And then what's the model of care then? So
if you are diagnosed with gestational diabetes, and just FYI, at the moment, we believe that about 12% of women in pregnancy will get diagnosed with it.
That's big.
That's big, but to be honest, I actually think it's getting higher than that. For example, the other day I was working on the maternity ward and 11 out of the 30 women who were on the ward had some form of gestational diabetes. So that's actually 1/3, not 12%.
When you say some form, some are insulin dependent?
Yeah. So I think it's actually becoming more common than 12%, to be completely honest. So if you get diagnosed with it, most important thing to know is that it is not a death sentence. Some women get really, really, really emotional knowing that they've been diagnosed with gestational diabetes, and what we know through research is stress is not really good for you in pregnancy, and it's really not good for you if you have problems with insulin and glucose metabolism as well. So
it just increases it.
Yeah, exactly. So once you get diagnosed, what we do is we set you up an appointment with a diabetic educator, and they will actually teach you what to do. What we actually ideally want to do is get you to test your blood sugar levels for the next 2 to 3 weeks, sometimes more, sometimes less, depending on your levels. And keep it in a diary. So we get you to test them in the morning and we get you to test them post meals and see what they are. If they're stable enough to be controlled with a healthy diet, then we call you a diet-controlled gestational diabetic. And it doesn't really impact on your pregnancy care that much. You can still be in a midwife.
No intervention.
No, you can still go into labour when your body is ready to, and our guidelines completely support this. You don't have to be induced. The only thing is, after your baby's born, we do test the baby's blood sugar levels for 24 hours to make sure that they're normal, because the concern is that the baby is used to having a higher level of sugar from your blood glucose, and when they're born, that level will significantly drop. So we actually want to make sure that the baby's getting enough food.
Mm-hmm.
And if after 24 hours the baby's blood sugar levels are normal, then that's all the testing you do.
Okay.
Yeah. We do recommend you do a repeat glucose tolerance test once you're 6 weeks postnatal. I think, though, the endocrinologists at work are only recommending this for women who end up on medication. So if you were insulin-dependent gestational diabetic, then we would recommend you do a 6-week test to make sure that it's definitely not still in your body, basically.
Okay.
Yeah. So if you are diagnosed with it and you're doing the testing and your sugar levels, whether it's your fasting or your post-meal levels, are really high and above a certain threshold, and they are consistently showing that, your endocrinologist and the obstetrician will actually recommend you start taking some form of diabetic medication to control that. And if that's the case, we do actually then recommend induction of labour at about 38 to 39 weeks, because we know that there's a few increased risk factors associated with insulin-dependent diabetics. So there is an increased risk of stillbirth if you go post-dates. There's also an increased risk of you developing type 2 diabetes for the rest of your life. So if you can control it with your diet, it's really ideal. I say to women, when you're testing your sugar levels, it doesn't matter what people tell you can and can't eat. You really need to go off what your body is telling you it can tolerate. And if you're eating certain foods that really set off, like for example, I had a woman who every time she'd eat Wheat Bix or toast in the morning, her sugar levels would be astronomically high afterwards. And even though her dietitian told her she could have that, I said, well, I think you should use a bit of common sense here. I don't think your body is metabolizing it very well. Stop eating it. Other people can tolerate that kind of food and it doesn't really set off their sugar levels that significantly. Disclaimer, I'm not a dietitian, I'm not an endocrinologist, I'm a midwife, but I work a lot with women with gestational diabetes, and also I try to use common sense. So try to be really mindful of what your body's telling you is what I tell women. And sometimes getting diagnosed with gestational diabetes is a wake-up call that your body is telling you that your lifestyle and what you're eating is not working for it anymore, and you need to do something about that.
Okay, and what's your thoughts on some of the recommendations by the dietitians? Because it's going off caloric intake, isn't it? Not necessarily looking at nutrients. So, I mean, they're trying to get you on a low GI.
They're trying to... What dietitians aim to do is they basically try and get you on a low-fat diet, because they don't want you to increase your weight too much in your pregnancy. The problem with that is that a lot of low-fat foods have a lot of hidden sugars in them. And we kind of know this. I feel like we've started to move on beyond the low-fat kind of era of eating. The unfortunate thing with anything, especially in government health, is that what we know through research can take up to 10 years to start to disseminate into practice. So the research with diet and food may be, really up to date, but we might be recommending things that we used to recommend 20 years ago that obviously are proven not to work. So always keep that in mind. And I can get women really upset when I tell them this kind of stuff, because they're like, I don't know who to believe, and you tell me this and they tell me that. And I always I say, well, you need to go back to what your body is telling you. So looking at your blood sugar levels, and when you're testing your sugar levels and you're looking at what your body is not able to tolerate and what it is able to tolerate, that is your number one source of information that you should be going off.
And I've had, I've got a patient, she's 6-year-old type 1 diabetic, and when she eats fruit, they're more stable. Her blood sugars are more stable with eating fruit than eating fats. It'll actually increase her needs for her insulin. So it is very individual, and I think like food intolerances can come into it.
Yeah.
But I mean, it's a massive topic. We could definitely chat a whole podcast.
Yeah.
And that's why on Thursday I'm going to be chatting with Brittany. So anyone interested to hear more about what we recommend for food intake, definitely check that podcast out. And she's going to be chatting about basically the research now, what the updated research, because there is quite a bit around like the Mediterranean diet, and but yeah, we'll go into that a little bit more in the next podcast. But I like how you said, I think everyone needs to just kind of go off their own intuition and individual intake and work with what works for them, because the guidelines, they need to be tweaked.
Yeah, and also when I look at the resource that the dietitian at work will give to women, a lot of it is recommending a lot of processed foods, to be completely honest. So breakfast cereals and low-fat yogurts and things that we know are highly processed. And I think there's a lot to be said in inflammation in the body and what that does to your body. And how your body is metabolizing those kind of foods versus foods that are minimally processed and really nutritionally dense and easily broken down by the body. And, so I think that's why I don't really agree with a lot of the diabetic resources that we do currently give to women. The other thing is I find, especially women who are from an Asian background, they have a diet that's really high in white rice. And I find, just as anecdotally, is that a lot of those women, the white rice that they eat will really increase their blood sugar levels afterwards. Yeah. Okay. And they find it really difficult to reduce that down because it's such a staple in their diet. But that could be actually the reason why they got the diabetes in the first place, if you're really thinking about it.
Of what else is on their plate.
Yeah, I think so.
Okay, so just moving on, thank you very much for touching on that, because I think it's a pretty important topic, and it is so common. I think I have 2 patients at the moment with gestational diabetes, and they both had PCOS, so it's so common.
Yeah.
I want to talk a little bit about nausea, hyperemesis. What's your thoughts on what to do? What do midwives actually recommend for women with nausea?
Yeah. Basically, again, most women who get really affected by nausea, it is in that first trimester, and sometimes it lingers a bit into the second trimester. And usually by the time we actually start caring for women, they've passed that intense period. However, we definitely do look after women who have ongoing nausea or a pregnancy disease called hyperemesis, and basically that just means extreme pregnancy, vomiting and nausea. So what I've found with women that works is you can go to your GP and get medication for the nausea if it's really debilitating you. And I think if it's really that bad, then if he needs a little bit of medication to basically survive and be able to get out of bed in the morning, then that's okay. Just be mindful that some of those medications can cross your placenta. So just try not to use them excessively or unless they're necessary, especially in the first 8 weeks of pregnancy when your baby's organs are forming. There is a lot of alternative things that you can try, like acupuncture, homeopathy, supplements like vitamin B12 and stuff like that.
So definitely acupuncture.
Yeah.
It's one of the first things I'd recommend. Ginger is a very common naturopathic thing. Chinese medicine actually doesn't like ginger in that first trimester because it's dispersing, so we're not trying to move things too much. One thing I've found really good is if people are taking the folic acid, the synthetic folic acid, getting them on an active version, so the folinic acid.
Yeah.
So if they have that gene mutation and they don't realise it, and they're taking that synthetic form, they're not metabolising it, and that can add to the nausea. The other thing that I find really good is activated B6, so P5P, pyridoxine 5-phosphate, which you can get in a health food shop, about 100 milligrams a day with food. Can be really good for that.
Yeah, and that's what I was going to say as well. See a naturopath, because this is the things that they're more expert in than what a GP or a midwife is.
Yeah.
If you see a GP, they're going to prescribe you a pharmaceutical medication.
Yeah. Yeah.
Basically. And the other downside of pharmaceutical medications is that they're really expensive. So a really popular one is called Zofran. It works pretty well, but it's really expensive. So if you can treat the nausea with an alternative therapy that's not doing any harm to your body, then I think that's actually a really smart financially path to go down. In extreme cases, of one woman I looked after, she was so sick. She was pregnant with twins, so the hormone called HCG that is thought to cause the nausea. We don't know exactly what does in pregnancy, but we know that there is an association of high levels of HCG and diseases like hyperemesis. So women who have multiple pregnancies have higher levels of that. She was really, really sick, and she actually said the only thing that made her feel better was once a week she'd go to her GP and get a bag of IV fluids put up, and that always made her feel better afterwards.
Yeah.
And I actually think that dehydration can play a massive part in how you feel.
So a hangover.
Yeah, exactly. So you think that it's the nausea that's making you feel sick, but the nausea is actually just dehydrating you, because women can't even drink water without throwing it up again. Yeah. So trying to balance your electrolytes.
Yeah.
Yeah.
And the other thing we do talk about is making sure you have adequate protein intake with all your meals to try and help support those blood sugar levels. But the thing is, if someone's sick, it is hard to sometimes get the food in, and specific foods that they might have eaten, chicken or egg, for example. I couldn't touch egg. You can't look at and eat because you're so sick. So it's kind of catch-22 there. But I find acupuncture and obviously the right nutrients, you might need to work with an acupuncturist and a naturopath on the side, can be pretty supportive.
Yeah, and it might seem like, to those of you who've not been pregnant before, that might seem like a lot of like using a lot of resource, but when you're really that sick, you actually really do need to. And women are desperate. If you told them to stand upside down on their head for 30 minutes a day, they would do it. They're just sick of being sick.
Yeah.
And their energy levels are so depleted because they can't keep any food down, and their teeth become really
because they're giving all this calcium to their baby that's trying to develop rather than for themselves. Yeah.
So I think really important is to stay hydrated. And I didn't really realise that until that woman told me, the only thing that made her feel better was a bag of fluids once a week, and for the rest of the day she could eat food and keep food down and not feel sick, because she had her body a bit more hydrated.
Okay, that's great to know. Okay, have we covered everything you wanted to maybe touch on for we've definitely dived into other trimesters, but in relation to the first trimester in particular?
I think so.
I think you've got you've given a lot of insight, and it'll definitely help people that have I think with the late model of care being at 20 weeks, it leaves women going, what do I do? Yeah. If they tune into this podcast, I think they can feel a little bit more calm about just patiently waiting, and and that's probably one of the biggest things, like I've heard you say multiple times, is just trying to relax as much as you can throughout the pregnancy, because there'll be hiccupes along the way, but sometimes it smooths out very easily. Yeah,
definitely. And I think, women have been giving birth since the beginning of time. So it's only really in the last, I'm not sure when ultrasound was even invented, but 50 years, I guess, where we've had these more medicalised pregnancies. So back in the day, you just were pregnant and you pushed a baby out, and that's how it worked. Whereas nowadays, I feel like, especially with social media, and women really stress themselves out in pregnancy about, I haven't bought this, and the baby room's not set up, and the da-da-da-da-da-da-da, and they get really, really, really overwhelmed. And I think, what do you need to buy?
There's a lot of taboo around that too, and we can chat about that, I think, maybe in the next episode. But a lot of the cultures don't bring anything home until baby's born. Yeah,
and I remember my mum said that she didn't even buy a pram till my oldest sister was a week old, which I think is a bit crazy, but that was back in the 80s. But she was like, I was walking around the shops and my arm was hurting, so I went and bought a pram.
Yeah, I think it's definitely good to be a little bit...
And I had another client... I had another client who was having a fight with her partner because he wouldn't buy her a $2,000 pram or something ridiculous because they couldn't afford it. And I think you're causing all this undue stress and you're focusing on all the wrong things there. Like, you don't need to spend all this money and send yourself broke and basically buy a small car worth of things to have a baby. And also, people buy all these things and they don't use them, so go on Marketplace and buy it secondhand.
Thanks for the extra tip there.
I say it to everyone. There's so many bargains out there. And then I also see and no disrespect, but there's a lot of Instagram influencers who make a lot of money off their pregnancy journey, and they are sponsored by a lot of brands, and so women look at all of that and all the things that they...
It just adds pressure.
It does, yeah. And they think, first of all, I have to look like that when I'm pregnant. I have to have all these products when I'm pregnant. And, I have to buy this and do this. And then they go on their mum Facebook group page and, it's just... There can be a lot of, stress and pressure from your peers around you who are well-meaning, but, just people push babies out in huts all around the world in the forest.
Yeah.
And they don't have a $2,000 pram to push the baby around in.
No. And we can obviously touch on the things like exercise and the kind of postnatal phase in that podcast episode, which I think is really important to share because social media does play a big role. But anyway, thank you so much, Emily, for this wealth of knowledge that you shared on this first trimester, and look forward to having you back on for round 2.
Thank you.
Thank you for listening. I have been a practitioner of naturopathic and Chinese medicine for over a decade. I have a master's degree of health science and I am an academic lecturer at Australia's leading natural medicine college. I am available worldwide online for bookings. Simply go to sandyrosshealth.com.